Okay, I would like to welcome everybody back from our break. We're going to start with our next next presentation. It does say on your agenda that Kirsten Garin is our next speaker, but Kirsten was not able to make it, so she was able to ask her boss to come. So I'm pleased to introduce Minette Richardson, who is also with ABC Diabetes, is a diabetes educator and registered dietitian. I will let Minette tell you a little bit more about how she got here and start her speech. Thank you.
Well, I'm delighted that I can fill in for Kristen, who's a phenomenal educator, and I hope I can do as well as Kristen. But I've been with diabetes education for a long time. I've been with ABC for over 10 years. My focus right now, besides the diabetes self-management, is recently I became a master trainer for the DPP programs in our area. So I actually teach lifestyle coaches for the diabetes prevention program. So that's a whole new avenue that we're working on. So I'm sure you all will be hearing more about the DPP programs too as that gets more involved in the different states and the practices. But what I'm going to do today is give you a little bit more information about what really happens in a diabetes self-management education program and how it really has and can improve your patients' outcomes. So I have no disclosures of financial conflicts of interest relative to this profession. I'm just a passionate person about diabetes education, as you will probably gather from my presentation. What we want to try and do is really have you understand the mechanisms of diabetes self-management education and briefly touch on the primary care referral algorithm, why it's important to know when is the time to really encourage your patients to go to DSME, and then really explore the benefits of DSME. We all know that diabetes is a chronic disease. However, a lot of times the individuals that come to classes don't, but it requires a person with diabetes to make a multitude of daily self-management decisions and perform complex care activities. So when they come to class, many of them don't even have a clue what they're getting into. So what we really want to do is help them understand the foundation to help them navigate the decisions that they need to make and really come up with activities that can really help them, because we know if they do that it's shown to improve their outcomes. And I've seen many, many people see so much positive after being in the classes. Unfortunately, the statistics aren't very good relative to diabetes education. It's really underutilized. Few people with diabetes receive this education. So you can see here about 44% of the population has received it and 56% have not. So that's really not enough people getting into diabetes self-management education. So let's really explore what goes into the program. I think that for physicians that refer your patients to DSME, hopefully you will see how beneficial it is. I can't tell you how many people say to me after they've been to the classes, "This has been wonderful. I'm so glad my physician sent me here." So let's just talk about it and show you where they do gain support and then share concerns. Diabetes, as we already know, is very complicated. We talk about lifestyle changes. We talk about risk factors. It's a very, very complicated disease. But what we try and do is take all of this and put it into a way that they can understand it, a takeaway message for them, so that they can actually take some ownership in what they need to do. So we try and simplify it for them. So who actually comes to the DSME classes? Well, we have individuals who have prediabetes. There are some, not enough, but that's hopefully going to be covered when we start having the DPP programs. But we do have people who have prediabetes, which is really great at this point that we can get them in there. Newly diagnosed is probably the majority of the individuals that we do have coming into the classes. Sometimes then when they start a whole new regimen of medications, that's when they end up coming to the classes. Or someone who is having issues with their control. And also, we might have somebody, and more we're getting individuals who've had diabetes for a long time, and many things have changed in their lives, and they need a refresher. And there are always things that are happening in diabetes management that are beneficial for them to learn. What is it that we provide? We provide a manual. So you'll see there, that manual is a really comprehensive booklet for them. It has a lot of information. We go through every one of the phases of education, and I'll go through each one of them. But they have their manual then, because when they come to classes, there's so much information that they actually are getting in class that we remind them that they have the reference. And I usually say to them after they've had a class, go home and review what we discussed tonight or this afternoon or this morning so that it's still fresh in your mind. And each person, because you saw the different levels or the different individuals coming at different times, for many of them, it's so overwhelming they really do need to go back and refer. So they have a really nice manual that not only has the core curriculum in there, but at the end of each class, we ask them to set up their goals for the next class. So they're building on different things that they want to do each class. We also have a knowledge assessment quiz. So when they first come to class, the very first thing that they need to do is fill out a pre-knowledge quiz. It gives them an idea of what they're going to be learning in their classes too. So it just starts from the beginning. And when we correct those, it's amazing how little most of the individuals know about diabetes and what self-management is all about. And at the very end of the last class, then we go through and have them retake the quiz, and then make sure they understand what the answers are. They also get a booklet that does their diary. So we do provide them with a diary so that they can manage their food intake, their physical activity, their medication, and their blood sugars. Now, many of them may choose another means, but at least we start with a booklet for them and show them how to use it. We ask them to bring it every single time they come to class so that we can review the numbers with them. So the diary gets them started at least, taking care of those numbers and what they're eating. We also give them a quick meal planning guide. So what we found is that many times they'll come to the first class and they think that all they need to do is have the food, and that's all that's going to be their treatment plan. We do give them a basic food guide in the first class, but when they come to the middle class, we get into much more detail with it. But it at least gives them the plate, it gives them an idea of what portion sizes look like, and it gives them something to at least start their journey and understanding about the foods, the food groups. So it's the quick meal planning guide. They can take it with them at home and then start building on it. When they get to the actual nutrition class, though, we want them to do a much more in-depth analysis of what they're eating. The glucometer is the other thing. Many times they'll come to class and they may have gotten a meter from their physician. They may not have gotten a meter. But we want them to know what the meter is, how to use a meter. So we do provide a meter for them. However, if they have a meter that was given to them by their physician, or if their insurance company gives them a different meter, we will show them how to use it. And what they are asked to do is to every week bring their meter with them so that we know for sure that they know how to use it. Now, I know some physicians will say you don't really need to test your blood sugars, which is fine, but we do want them to at least know how to use it, take that step for them so that they at least know what it means, and we explain to them how those numbers have some relevance to them. So while the physician may make a determination of whether they want them to check once or 4 times or every other day, at least what they're going to get is the capability of testing their blood sugars when they come to class, and we do provide them with a glucometer. So again, it's the step-by-step. So it's interesting to see how some people will come to class and we show them how to use the meter, and you try and show them how to put the lancet in the meter, and the second class, they still haven't figured out you actually have to put it into the meter because they get so nervous, and that's the type of thing that takes time. And that's what we want to make sure that we show them how to do it, how to actually use it correctly, how to make sure that they take their meter with them when they need to, and how to get new strips, how to work with their primary care and prescriptions for their strips if they need to get the prescription. Usually when they leave the class, we have to make sure that they know if they're going to get prescription strips, they have to work with their physician. So we go through the whole process of how to use the lancet, how to use the meter, and how to actually access their materials and supplies. We also, again, this is a pretty comprehensive class, so we want to be able to give them the information that other people, as primary care physicians and endocrinologists, nobody really has that kind of time. So we go through all of this in a pretty detailed manner. So we talk to them about the ketone sticks. We have them use it. If somebody came to class and their blood sugar numbers were really high, we will ask them to maybe test their ketones if we're going to take a walk, because we don't want them to be taking a walk if they're spilling ketones. So we go into the details of when you might use ketone sticks, where you could access them, and how they're used and what they look like. We also talk about the carb counting. I know that Dr. before talked about the importance of carb counting, so we go into great detail of how to look at the food and what foods have carbs. We also go into how to read a nutrition facts panel. We actually do label reading in classes. Everybody gets a chance to look at a label, figure out how to read it. Many times they have no idea that a portion size is what you're looking at, and that you need to correspond the portion size to the actual carbohydrate content. Some of them are on sodium restrictions, so we will also review the sodium component of it. We also talk about highs and lows in the blood sugars. So we really review the importance of treating a low blood sugar and what to do if your blood sugars are high. We also go through the importance of checking your feet and how to do it. So it's part of the complications that we talk about it. And in fact, this past year, what we found is that we had a significant amount of people when we did our 3-month follow-up were not checking their feet adequately. So we developed a CQI for the particular quarter where we were looking more specifically how we could educate them about foot care and put a whole new section about foot care to hopefully improve the outcomes relative to foot care, and we found that it was successful for us. So we put more emphasis on the importance of that. We also go through a whole section on complications. So what happened is that we found that individuals that came in and said, oh, I just have a touch of sugar, or they didn't really understand what diabetes was all about. So what we figured was an important component was to really explain to them that if they try and do the best that they possibly can to keep their blood sugars in good control, watch their blood pressure, and do the lifestyle changes that have been recommended, take their medication, that they could really reduce the complications. So we go through pretty much every one of the complications from retinopathy or macular degeneration to some of the complications from the, neuropathies, kidney disease, cardiovascular disease. So it gives them a much different perspective of why they're there and the importance. So we want them to really understand what they can do to try and reduce some of the complications. We're all looking for reducing the complications and having better outcomes. So that's a pretty big emphasis when we explain to them the potential that they have to reduce their complications. We also talk about, because stress, we now know stress can have a huge impact on how successful they can be. So we have a whole session on stress and stress management. We actually do a stress management activity in the classes. So when it comes to the top, we do the monitoring, we show them, and we do a physical activity actually in the classes as well. So we try and give them a little experience and exposure to everything. So again, it's a 10-hour program. So you can see for 10 hours, they get a lot of information and a lot of feedback. And because it's a group class, there's a lot of interaction. So when you have a lot of different individuals with what they feel is important and how it's going to help them, it makes for a really interesting classes. So it's 10 hours. It's generally 3 classes. It's in 5 sections, but it's 3 classes. And it's taught by a certified diabetes educator. So let's look at the 10 hours of program, overview of diabetes and the disease process. So we really try and give them up front exactly what's going on. We show them how to monitor their blood sugars, how to do urine ketone tests, and how to use the results for problem solving. Medication management. I know earlier Doctor was talking about so many different kinds of medications. We review the medications and algorithm with them so that they understand. We know that there's a very low compliance in medication management, so we want them to really understand the positives of taking their medication, when they should be taking the medication, and how to refer to their physician if they have concerns or questions about their medication. It's amazing how many people will come to class and have no idea when they're taking their medication or when they should. So I had one gentleman say to me one time, he was going on insulin and he had been on all these oral medications. When I asked him, when do you take them? He said, oh, I take them all at once in the morning. So he was taking all of his metformin and his sulfonylureas in the morning instead of splitting them twice a day. So he never really understood his medical management. So we do try and work with them to make sure they understand that and they're compliant. Preventing, detecting, and treating acute complications. So as I said, we really emphasize that they have some potential control in reducing those complications if they make lifestyle changes and they follow through on their management from their primary physician. Again, preventing through risk factor reduction and treating the complications. So if they do start having a problem, we want them to know that they need to take care of it right away. Nutrition management. This obviously is the biggest component for most of them because they never know what to eat, when to eat, how to eat. They have really very little understanding of carbohydrates, most of them. So nutrition management takes on a big, huge role in DSME. So we spend a lot of time trying to personalize and educate them to their meal planning. And everyone's different. Physical activity. This one tends to be such a priority for all of us to get people more mobile and doing physical activity. So as I mentioned earlier, we actually do a physical activity exercise in our classes. So what we do is we'll have them test their blood sugars and then generally do a 15-minute walk when they come back. We wait 15 minutes and we test their blood sugars again. And you would be amazed at the number of people that are just shocked at seeing their numbers come down. Now, if we have an individual in the class who really is not that mobile and doesn't feel comfortable walking, the educator stays in the room and will do chair exercises or whatever exercises they're comfortable with. We also have a video to show them how they can do that at home. So it's one of those barriers that we hear about all the time about physical activity. So we try and engage them from the beginning on how they can do little steps to incorporate physical activity in their lifestyle. And again, I have many people that say, I can't walk, I won't walk, or whatever, and we just do chair exercises, round their arms, and all of a sudden they notice that even with that, their blood sugars come down. Psychosocial adjustment. Again, because we know that depression can be one of those huge barriers for them, and if their blood sugars are not in good control, it can also affect how they're feeling. We discuss that in class, and we ask them to try and be open, and how do they cope with it. So usually before we do our we do an exercise in it's basically giving them a chance to meditate, but most of them talk about different ways that they can incorporate some kind of stress management in their daily life, and we work on that and ask them to be thinking about it. So our stress management exercise is about 5 to 10 minutes long. We usually have them close their eyes and contemplate. We have a video going, or we have an actual readout of a stress management tool. So they never really think about that, but it's a good exercise for them to really start thinking of how to take this really seriously and reduce their stress. Setting behavior goals to promote health. So from the very beginning, we start working on those behavioral goals. So the first week after the end of the class, after each chapter, we have small behavioral goals that we ask them to start working on. This is where we're looking for ultimately the outcomes. But we all have to come to some place in time where we have to develop a behavioral goal to get us started. So it's really difficult because lifestyle changes is really pivotal. So most of these people have many, many years of lifestyle that they are really resistant or have major barriers to change. So it can be as small as 5 minutes a day of doing some kind of physical activity 3 times a week. It might be that they just go get measuring cups to measure a portion size. It might be that they go to the grocery store and look at their favorite cereal and look at the label on it, to start these small behavioral goals to help them to promote their health. So again, at the very end then we have a diabetes self-management support plan. So overall, after then, because we're going to go through the different times that they may be coming to class and what their support needs may vary depending on where they are in their whole diabetes management. So what are the program goals? To improve self-care knowledge and skills, to increase compliance with self-care regimen. We're taking them from the doctor tells me to do everything to I need to do this for myself. I mean, I think it's a whole new mindset for many of the individuals that come that they need to do some self-management. Increase the compliance with the medication regimen. Again, many individuals come to the classes. They don't know what the medication's for. They don't know whether they should be eating. I can't tell you how many have been on sulfonylurea and couldn't understand why they were having real drops in their blood sugar, but they didn't eat breakfast or they didn't eat a meal, and all of a sudden their blood sugars were bottoming out or they were shaky. And their response was, the medication doesn't work for me, rather than looking at the regimen or when they're taking it was not appropriate. So we want them to be able to take their medication, understand when they should take their medication. Same with insulin. When they're on a bolus insulin. I had a fella come to class who took a bolus insulin and he didn't eat. So by the time we were halfway through the class, his blood sugars were bottoming out. And I said to him, and everybody in class could understand the episode because he dropped so low. But it was a teaching moment for everyone in the class. But it's important they understand how to take their medication and when. Shorten the lengths of stay for inpatient hospitalization. We're all charged with that, to keep them in the hospital for a small amount of time as possible if they end up in the hospital. Improve glycemic control as demonstrated by the actual A1Cs coming down. Looking at those numbers. Decrease ER visits. I know my daughter works in an ER and she says about 60% of the individuals that come to the ER are individuals with diabetes that have some kind of a problem, and they're coming to the ER. So we're all, again, as healthcare providers, looking at ways to decrease the ER visits. Overall reinforcement of patient compliance with a primary care physician. Again, we encourage them to communicate with their primary care physician. They come in there, they're afraid, they're angry, they have all kinds of resistances. They'll say, my primary care isn't available for us or for me, and we encourage them to really pursue that communication with their primary care physician. It's critical for their care to have that relationship. So, again, our focus is to make sure that they're making the lifestyle changes that they need to make. So we identify the behavioral goals in the following areas, which are then used to monitor their progress. So the risk factor reduction, we're all looking at that. Stress management. So we want them to really identify if they are very under a lot of stress. What often I will suggest to individuals, if they come to class and they're very stressed and they're very anxious, this is another time I'll say to them, you need to have that conversation with your physician to see if there's some intervention that your physician would recommend for you if you are really finding that this stress is interfering with everything else. I've had people come and they start crying in class, and they haven't really let their primary care physician know that they were dealing with such emotion. Meal planning. This is one, again, that takes a lot of time. Most of the individuals who come to the classes are overweight, and it's really difficult for them to think about making some changes. But I love what he had said earlier, Doctor said earlier, about reducing that snack at night or reducing in the evening, because if that's going to help them with their blood sugars, that's really important. The one thing that I have seen many times, just to relate to what he had said earlier too, is those high blood sugars in the morning. We have a lot of individuals who do tend to have high blood sugars in the morning. Many times they are doing the Smoji effect and they haven't had anything to eat at night. They need to evaluate whether or not they're eating properly before they go to bed, or if their blood sugars are dropping in the middle of the night. So we talk about that and what they might want to try and do to help with those blood sugars that are high in the morning. Sometimes it's because they're not taking their medication properly either. Achievement and maintain the desirable weight. In the time that we have them in the DSME, it's only the beginning of identifying where their weight might be. We do have advanced classes where we go into more detail with this, but at least we want them to identify where they need to be. So it's not necessarily a 50-pound weight loss because it's not realistic, but to at least start making the lifestyle changes to help them come up with a desirable weight that they're comfortable with and at least make the intervention. Blood glucose monitoring and the use of the result. Often what they don't understand is the cause and effect of food, medication, and physical activity. So that's why when we do the physical activity exercise, we show them the before and the after when they monitor their blood sugars. Same with eating. We'll ask them, what is the most important thing for you? Do you want to figure out if the meal that you were eating was way too high in carbohydrate for you? Well, then testing after you've eaten is more important. If you're taking a medication like a bolus insulin, then you need to look at your blood sugars before you take your medication. So we try and review all of the different scenarios on an individual basis depending on where they are. Monitoring of ketones. The bigger issue for the ketones tends to be identifying when they're sick, because we don't see them usually that their ketones are, by the time they get to the class, they tend to be in a little bit better control than maybe when they were in the hospital or if they were in the ER. But we do talk about it, but we do emphasize that when they're sick, that may be the most important time for them to test their ketones. Again, I found that there are certain physicians that don't feel that this is necessary, but we at least give them the background as to what ketones are and why it's important to test at certain times if appropriate. Physical activity, as I mentioned earlier, it is one of the things that we work on very hard to get them to think in physical activity terms. If it's just 5 minutes a day, twice a week, 3 times a week. Daily foot care, you get those same obstacles. I can't see my feet, so we talk about different ways that they can look at their feet. I had one fellow say to me, oh, I can't look at my feet because my belly's too big. So I asked the class, how do we problem solve this? And so, of course, they all said, he just needs to go up to a mirror and put his feet up. So it came from the group class, and then it resonated differently. The retinal exams. Again, many of them don't really correlate between the eyes and elevated blood sugars and the potential for them to have eye problems. So we do encourage them to make sure that they get their eye examined. The other thing we might suggest to them, or I always do, if their blood sugars are really high, it's not a good time to get a new pair of glasses. Because some have come to classes and they say, I can't understand it. I just got these brand new glasses and they don't work. Well, the blood sugars are coming down. So we try and let them know that the time to really go for new glasses is once their blood sugars are in target range for them. But it's important to have your eyes tested. So before they actually come to class, the educator will call the patient. Introduction. So I'll say, Mrs. Smith, my name is Minette Richardson. I'm your educator for class on Saturday. I wanted to make sure that you know who I am. I'm glad that you're coming. Is there anything that you have a concern about before you even come to class? So sometimes that helps the barrier. We talked earlier about how often you may refer them to class, but they don't go to class. So what's important with a DSME is that there's their contact before they even start the class. At that time also a health assessment is done, usually to find out the history, the lab values, past medical history, family history, medications, if they're testing their blood sugar, if they're doing any exercise, nutrition, and goal setting. So before they even come to class, we try to get them to be thinking what it is they're going to be learning about and what are some of their goals. So this just gives you an idea what we do, a worksheet and support plan. And this is based on the recommendations of the American Diabetes Association. So these are the ones, these are goals that are set that 3 months and a year after are followed up. And this is the kind of information as primary care physicians you would want to know. What is it? So if you're sending your patient to a DSME class, what is it that the patient really wanted to do? So these are the goals that they personally choose. It's not the educator, it's not somebody in the class. This is what they are choosing for themselves and what kind of support plan they may have. The tracking record, I know that because a DSME program does have the guidelines, there are things that have to be addressed. And so the tracking record just basically gives you what the content of the information is and whether or not they actually understood it or where they were. And then also the meter and whether or not they could actually use the meter if they had any problems with the meter. And then again, the pre and the post quiz. So that's another parameter that we look at as to whether or not they've actually gotten anything out of the class. So this is the pre-quiz, and then they take the same quiz at the end. So the starting point, patient identification via the staff or the electronic medical records, exam room, the PCP time. So these are the times to actually generate a referral. I would go on to, because I want to show you, why is it not going? Okay. I just want to make sure I show you where the new guidelines are. According to the American Diabetes Association, what critical times to assess and provide is with a new diagnosis of type 2, annually when they come in for maintenance and the prevention of complications. If something new happened that's complicating their self-management, transitions and care. So the question, which is the correct answer? Why is it not working?
Yeah, you may have to reset it.
Do I go back?
You just have to pause before you show this. We have to just wait to let everyone get their full in. Yeah.
What do the?
Guys, gonna reset it. I'm gonna show you. Because we can't, unfortunately, we can't see the polling numbers, but we can back there. So we'll reset it, and then start with the question I am A. Yeah, we'll start there.
All right. I didn't realize that was, all right, I am a physician,
Okay, so
nurse
he's
prac.
gonna reset this. Okay, so click to the next one, and then don't click again until we give everyone a chance to enter their. Give everyone like maybe 30 seconds, and then click, and you should see the answers.
All right. Am I ready? It didn't go. All right. All right. Well, we'll go to the next question anyway, because
Yeah, just have to pause before you go to the actual chart. You just have to.
I thought I
pause
gave
for a moment to
everybody
make sure it's
time.
working.
All right.
Maybe try the next question.
According to the ADA, what are critical times to assess, provide, and adjust DSME? Choose one answer. Is it working? Can I go to the... I'm sorry, Dr. Sutton, I'm a few minutes so. Should I go ahead and click it? See, it's not working. All right, show of hands. I'll tell you what the answer is, though. It's all of the above. All right, so in transition to care and so forth. So for critical time, so this was published in 2015, new diagnosis annually, complicating factors and transitions. So those are the times to refer them to diabetes self-management. Here again, what types, when, so all new diagnosed in the first 12 months, if they're established, if they have any of these complications, again, on a routine visit if you see some changes, and if they're transition of care. So we've seen that too, where all of a sudden it's a single male who's lived with his wife all of these years, and now all of a sudden he's by himself. So that may be another time to send them to class. Here, again, some from the medical records, if their A1C is going up, any kind of renal issues, their blood pressure, medication, BMI, tobacco user. So question, how is diabetes affecting your daily life and that of your family? What questions do you have? What's the hardest part right now? And how can we best help you? So now what, you've identified the patient as being a good candidate. So what is the best method? Here's a question. Let's see if this works. Electronically referral, hand referral. All right, have I given everybody enough time? It's not working? All right, well, if it doesn't work, I'll give you the answer. Still not working. So the best is electronically or a referral form, because a hand referral never gets where it's supposed to go. So we know that directly faxing or within the practice, somehow the referral needs to go directly. If you give them a prescription to go for DSME, they won't follow up. So that is not the way to go. Handing the referral just does not work. So after the referral, patient and outreach will, a DSME should contact them. They verify the insurance and the billing, so that's out of your hands. The program, I already mentioned, we go through and introduce, prior to the start of the program, this is the DSME standards, the pathway after the individual gets started, all of the different things that they are supposed to have intervention in. So what's the benefits? It's a one-stop shop. They have confidence in testing, carb counting, label reading, and self-care. So this is what the benefits are. It improves outcomes, help delay some of the complications, and it's a pay for performance in QI. So it helps primary care. Everybody in the healthcare arena now is looking for those performance and QI goals, fewer complications, they take their medication, cuts cost. Here's the last question. A study done by ADA published in Diabetes Spectrum found the A1C level drop. I don't know if it's going to work. Is it working? No. All right. So the answer is to 7.8. So we definitely know that there's. So I don't think I have time to do a practice case study, but I think what's really critical for everybody to understand is that we know that individuals do see a significant reduction in A1C. It reduced readmissions, hospitalizations. Individuals were more confident with their care, and they love the courses. get to know your diabetes educator. So for those of you that in your area, try and find out who your diabetes educator is, build a relationship so that you can work with them. Similar to what Doctor said about working with the endocrinologist. In closing, teaching all this information takes time. The DSME is actually a support system for the primary care physicians. So refer your patients to DSME for comprehensive education and behavior modification. It's a win-win for everyone. So, should we see? Not going to worry about this because it's not working. All right. Well, I hope that this gave you a little insight into the DSME. Does anybody have any burning question? Because I think I went over a little.